hypothyroidism and 4 P's of pregnancies. Our speaker for today is Dr. Manish, and sir is a practicing at a gynecologist and obstetrician at Mahavir Hospital and Manish IVF Center at Surendranagar. And it's honors to have you here, sir. Before handing over to you, sir, I request all delegates to write their queries in chat box so we can address it part of your sessions. So thank you, sir, and happy to hand over the session to you, sir.
Thank you, Mr. Vara. This is my 128th webinar of Abbott since 2004. I am happy to share these two QR codes. One of is there of ORCID, which shows my 118 paper. We have got DNB DGO seat up to 2017. 53 resident already passed and 4 are doing residency. We got FOXI recognized ART, IVF and ultrasound training with ICOG fellowship in reproductive medicine and laparoscopy. One fellow is already passed in reproductive medicine and 2 students from BMCC Delhi, they are coming for endoscopy training at present. 8 book written by me, it is published by JP Publication. 3 chapter on postgraduate series, 1 chapter on DUB. Total 66 paper published, out of that 51 in Indian Journal of Obstetrics and Gynecology, 5 paper in Indian Journal of Basic and Clinical Pathology, 3 paper in International Journal, that is Open Access Journal in Gynecology, which is published from Michigan, 2 paper in IJMPS and 2 paper in IJOGR, and this is my 763 presentation of webinar till date. Today we are going to discuss 4 P's of pregnancy and hypothyroidism, that is pallor, preeclampsia, preterm and postpartum hemorrhage, and third one is Pandya, which is narrating all these diseases. The moment child is born, mother is born. Mother is there, she is there, but mother is something new. How beautifully everything is arranged by Almighty, that when child born, mother is ready to take care of it. With the blessings of Mother of Mind, 3 book written by us, that is step-by-step male infertility, gynecological endoscopy, and active management of labor is recognized in Royal College as a reading material. Textbook or Atlas of Fetal Echocardiography now for 2nd edition, and now I am writing textbook of fetal echocardiography, and this book was published in 2005. When nobody knows about the antenatal scan, we had written a book on fetal echocardiography. The technique of IVF made easy now is available as a 2nd edition in market. This is a 2nd edition book which contains more than 12 chapters from the 1st edition. I am editor-in-chief of Indian Journal of Obstetrics and Gynecology. This is Coppock recognized journal, and also associate editor in Open Access Journal of Michigan. Recently, I got visited Copenhagen and taken interview of Professor Herman Tunne, which is there in Lotus Trial, and you can see all these videos of 178 presentation in Manish 4269 channel. This is disclaimer by Abbott. Hypothyroidism. Megha Jani advocate. Sorry. This is hypothyroidism during pregnancy. What is Indian scenario? Dhanwakar et al. In 2016 has done cross-sectional multi-epidemiological study on hypothyroidism in pregnancy, and they say that hypothyroidism affects 13.13% of pregnant women with cutoff value of 4.5 microinternational unit per ml. It is a trimester specific. TSH cutoff less than 2.5 milliliter for the first trimester and 3 less than 3 international units. So our range should be in pregnancy from 2.5 to 3. If it is less or it is more, then we have to treat the patient accordingly. 80 TPO antibodies were positive in 20.74% of all pregnant women. Most of them were subclinical hypothyroidism. And believe me, subclinical hypothyroidism is causing lots of difficulty nowadays. Subclinical hypothyroidism. What is Indian scenario? Mandal and et al. Done 2016 cross-sectional study of 510 subjects were conducted to evaluate the percentage or prevalence of subclinical hypothyroidism in pregnant women during the first trimester. The prevalence of SCH was 32.94 TSH value more than 2.5, normal with pre-T4. TPO antibody were positive in 33.93% and subclinical hyperthyroidism were only in 1.47% of normal subject where a TPO antibody were positive. So TSH level more than 4.5 was estimated in 13.92% of subject, and subject with TSH more than 4.5, 70.42% has got positive TPO antibody. Now let's take all this different case scenario in my presentation to do the 5 P's in pregnancy. This is 31-year-old primary gravida, visited our place as a routine antenatal visit in third trimester. First trimester TSH was 2.5. We all know that reference value is 0.1 to 2.5, and we had seen that 2.5 to 3 is the range in which we have to run our pregnancy. HB was 10.2. In second trimester, at 18 week of gestation, on repeat CBC, hemoglobin was dropped from 10 to 8. She was diagnosed with moderate anemia. RBC indicates were suggestive of iron deficiency, for which we had given injection FCM, and I am happy to share that all these 3 iron molecules, iron sucrose, iron peroxycarbose maltose, and iron isomaltoside, on all 3 molecules we had done study, and it is published in reputed journals and it is available on ORCID. Ferrocarboxy maltose we had done study in 2012 of 480 patients, 486 patients on prescription based study, and it is very well appreciated by all companies. So we have started to repeat CBC and TSH after 4 weeks. Our results at 22 week of gestation, there is elevated TSH 5.67. Again, it is out of range, but HB was 9.1. So she was diagnosed with hypothyroidism and was managed with levothyroxine 50 microgram per day, and she was advised to take tablets ferrous sulfate 200 microgram followed with repeat CBCs and TSH after 1 month. So in case 1, she was diagnosed with hypothyroidism during pregnancy along with iron deficiency anemia. 50 microgram of thyroxine was initiated, associated with ferrous sulfate 200 milligram per daily, and follow up after 1 month. What happens when she has got anemia associated with hyperthyroidism? What is Indian scenario? The data from National Family Health Survey indicates that 50.4 to 52% pregnant women in India are anemic. Nowadays, so many companies have initiated their motive, Anemia Mukt Bharat. That is the notion of our President, Dr. Sunita Tendulkar, of FOXY this year, that we have to give all the nutrients to a woman preconceptionally, during pregnancy, and even in postpartum. The Indian study published in 2020 has demonstrated that the prevalence of hypothyroidism in pregnant women with iron deficiency anemia, believe me, it is more than 35.29%. So, there is a bidirectional link between the hypothyroidism and anemia. What is that bidirectional link exists between the iron deficiency anemia and hyperthyroidism in pregnancy? And because of anemia, there are lots of complications occur in pregnancy, like preterm delivery, premature rupture of membrane, preeclampsia, and intrauterine growth restriction, or SJs, small for gestational age baby. So what is predisposes to iron deficiency anemia? Because of deficiency of thyroid hormone that lead to suppression of euthyroid precursors of proliferation and maturation. Hypothyroidism can influence the iron hemostat by affecting expression of specialized protein, maintaining the balance between the ferritin, transferrin, ferroprotein, and hepcidin. So there are molecules which are available in market which doesn't require hepcidin, and hepcidin block is that we all know because of hepcidin block there is iron deficiency anemia in pregnancy. So there is a bidirectional effect of iron deficiency anemia and hypothyroidism. Iron deficiency reduces the activity of thyroid peroxidase, that is TPO, and a key heme containing enzyme, that is thyroid hormone synthesis. We all know that our all pregnancy that depends upon the hypothalamo-pituitary ovarian uterine function along with help of thyroid. It contributes the dysregulation of thyroid metabolism due to following alteration, like decrease in thyroid stimulating hormone, that is TSH, response to thyrotropin releasing hormone. So decreased TSH will lead to decreased TRH. So defective organification of the iodine, suppression of deiodinase activity, and impaired binding of T3 to its nuclear receptor. What is Indian scenario or Indian study which says that there is a specific relation between the hypothyroidism and anemia in pregnancy? Gupta and et al. Done the study in 2022 to have a relationship between iron deficiency anemia and function of pregnant woman. This was a cross-sectional observational study to evaluate the relationship between iron deficiency anemia and thyroid function in pregnant women, particularly in first trimester. Total 113 first trimester pregnant women were screened, and finally 100 enrolled in the study. Inclusion criteria: first trimester pregnant woman with that attending our antenatal clinic. Exclusion criteria: second trimester pregnant female, female with known history of thyroid disorder, dysmorphic anemia, and ongoing acute infection, or they are taking iron supplements. The study population was divided naturally into the two groups on the basis of serum ferritin level. The second group with first group has got serum ferritin level less than 15 microgram per deciliter as defined as iron deficiency anemic, and second group with serum ferritin level more than 15 microgram per deciliter was defined as non-iron deficient. Here cutoff is 15 microgram of ferritin level. What is result? 68% of female, including on that present study, was iron deficient, while 32% has got normal iron level. The serum TSH level of 74% female was normal. 26% female has got increased serum TSH, with all having normal free T4, hence diagnosed with subclinical hypothyroidism, that is SCH. The iron deficiency group, 68 women, has got 35.29% of subclinical hypothyroidism, while 15 women has got increased anti-TPO level. Total 16% of female has got increased serum anti-TPO levels, while 84% of female has got normal serum anti-TPO level. So normal iron group, that is 32 female, has got 6.25 of subclinical thyroid hypothyroidism, and only one has got increased anti-TPO level. So there is a significant association between the subclinical hypothyroidism and increased TPO level, and you see the study is very significant. P value is less than 0.0001. Very significant study. So serum ferritin and TSH level were negatively correlated with correlation coefficient of 0.335. P value was 0.007. Serum ferritin and anti-TPO level were found to be negatively correlated with correlation coefficient 0.445, and P value was significant 0.0001. So there is a very much impact on thyroid function and regression analysis result. You all know that all the study we have to put on regression analysis. So what is the impact of variables on subclinical hypothyroidism? Iron deficiency was associated with increased risk of subclinical hypothyroidism with odd ratio of 8.2. Age or BMI does not show any association. What is the impact of variable on thyroid autoimmunity? In iodine deficiency was associated with increased level of anti-TPO with odd ratio of 8.7. Here also there is no association with age and BMI. So what is treatment option should be given to all these patients? We all know available option is levothyroxine, and we all know that levothyroxine improves iron deficiency. So levothyroxine should be implemented in all these patients with iron deficiency anemia. So correcting thyroid function is necessary to improve iron status in patient with subclinical hypothyroidism plus iron deficiency anemia. Adequate thyroid hormone level enables the correction of iron deficiency anemia and facilitates bone marrow response to iron replacement. So levothyroxine therapy enables the desirable therapeutic effect with the iron replacement to prevent ineffective iron therapy. So believe those patients are refractory after giving iron deficiency anemia treatment, and if you do thyroid function test and if she found subclinical hypothyroid, better to supplement iron with levothyroxine depending upon the TSH level. So what is the optimal management of hypothyroidism? Is to integrate treatment of anemia. The prevalence of iron deficiency anemia is very high among the all pregnant women. I already said it is 38%. So low iron level may affect thyroid hormone, resulting in higher TSH and lower free T4 level in the first trimester of pregnancy. So early detection of thyroid hormone should be encouraged for optimal management of pregnant women. So it is my earnest request to all gynecologists, better to screen all these women in first trimester with simple test, that is thyroid stimulate TSH test. Usually we are doing hemoglobin. Now our president Dr. Sunita Tendulkar has initiated the Know Your Numbers, in which we are doing her hemoglobin, her weight, her BMI, her blood pressure, everything. So she should know their numbers. Likewise, we can also include thyroid function test in the patient. Because of this screening test, we are able to know that she is suffering from subclinical hypothyroidism. And once we able to diagnose that she is hypothyroid, we can have a levothyroxine, and it is crucial for development of baby as well as mother, because we all know that subclinical hypothyroidism or severe hypothyroidism leads to cretinism in the baby. So nowadays we are also doing thyroid TSH in the newborns to screen out that those babies does not have this impact of hypothyroidism during their early neonatal phase. Again, now revisit the case. First case we had done, euthyroid status was there in first trimester with hemoglobin elevated, but she was advised to continue levothyroxine tablet with ferrous sulfate. So we know that in first trimester it was in the range. In second trimester it was increased and hemoglobin was decreased. So we have to give levothyroxine. And third trimester, after initiating the levothyroxine, her thyroid level remained normal from 5.67 to 2. And after giving thyroxine with iron, her hemoglobin is increased after one injection of ferric carboxymaltose. So it is a very good drug. It should be given within the speculated 15 minutes of time in 100 ml of normal saline. It is the drug with very less hepcidin block, so it will increase the hemoglobin level, particularly in iron deficiency anemia patients. If there is subclinical hypothyroidism, always add levothyroxine to all these patients. Now look at the case 2. This is 42-year-old lady, elderly lady with 17 weeks of pregnancy with history of Hashimoto thyroiditis, treated with levothyroxine 150 microgram per day, referred to our clinic with early onset of preeclampsia. She had got blood pressure of 180 by 108 with proteinuria and headache. First we had started nifedipine 3 times a day. Then with the history of she has got one vaginal delivery with 3 abortions. We had taken this into our account. TSH was 14.9, free thyroidine, that is 1.6, free thyroxine was 0.65. On the account of elevated TSH and low level of free T3 and T4, levothyroxine we have to increase from 150 to 175 microgram per day. On ultrasound, there is very high uterine artery Doppler. We all know that this is normal uterine artery Doppler, and with this there is uterine artery notch, and this notch says that patient is suffering from PIH, and we had seen systolic notch as well as diastolic notch in uterine artery. Umbilical artery Doppler was also abnormal. 24-hour urine collection, the protein was 1.5, which is very high, which increased from 6.8 gram per week. So it is very high proteinuria. So glomerular filtration rate was very high. So it is on glomerular based negative disease. Complete screening of autoimmune disease resulted negative. Due to persistent high blood pressure, we had added alpha methyl dopa. Repeat investigation again says markedly elevated TSH and level of free T3 and P2 are continue to decrease. Proteinuria reaches from 6.8 to 9.8 in 24 hours. So we added atenolol with risk versus benefit ratio. Again, ultrasound on 19 weeks shows increased resistance in uterine artery. Bilateral notches are there. Umbilical artery DOP4 says this is absent diastolic flow in umbilical artery. This is absent diastolic flow. This is normal umbilical artery with good diastolic flow, but it was not reversed. There is ascites with bilateral pleural effusion at 20 weeks of gestation. So albumin was added with diuretics. Proteinuria reached from 6.8 to 11.31 in 24 hours. High blood pressure was there, so it added labetalol 25 microgram per times in a day with high TSH level with increased levothyroxine from previously C was on 150. Now it increased up to 275. So diagnosis was severely uncontrolled hypothyroidism with pregnancy. So in this type of preeclampsia patient, we have to understand the pathophysiology. Thyroid hormones are involved in regulation of placental development, endothelial function of the blood pressure. Recent theory in preeclampsia is vascular theory. Whenever she becomes pregnant, there is formation of zygote. Zygote invaded into the endometrium with increasing implantation. So we are eroding our mother's endometrium and implanting cells. Then there is formation of chorionic villi. Condensation of chorionic villi become chorionic frondosome. Condensation of chorionic frondosome becomes cotyledon, and condensation of cotyledon becomes the placenta. And this all placenta is nurtured by uterine artery, converted into arcuate artery, then radial artery. And here are the syncytotrophoblast and cytotrophoblast cell. They are traveling into these arteries, and believe me, they are destroying the muscular cord. So in uterine artery, there is only serosa and intima. Because of inadequate destroying of this muscular cord of these vessels, there is notch. You all know that notch is because of the pulsatile impact. When there is improper phagocytosis of this muscular cord, there is decrease in the arterial lumen. And that is the latest theory in PIH, that at vascular theory, improper phagocytosis of the muscular lever by syncytotrophoblast and cytotrophoblast. Thyroid has been associated with cell dysfunction, likely secondary to decreased production of vasoactive substance, that is nitric oxide. We all know that nitric oxide is potent vasodilator. When in our body, arginine is converted into citrulline, there is formation of nascent nitric oxide, and that nascent nitric oxide is a vasodilator. Two drugs, that is arginic acid and dydrogesterone, will give the same effect of increasing nitric oxide in the body. So because of there is decreased nitric oxide, there is impaired vasorelaxation, increased sympathetic tone, increased vascular resistance, and ultimately resulting in hypertension. Critical process during placental formation such as decidual migration and angiogenesis are regulated by inflammatory mediators such as influenced by thyroid hormone. Consequently, the condition with a low thyroid hormone availability may result in inadequate anti-inflammatory environment in the developing of the placenta. So say there is placental vascular dysfunction. We all know that dydrogesterone is causes of pregnancy conducive immunomodulation. There is formation of protective cytokines, there is formation of asymmetric antibody, there is decrease in the natural killer cell, and there is formation of PIBF, that is progesterone induced blocking factor. And because of that, we are able to implant ourselves into our mother's womb because of positive immunomodulation. If it is not there, then there is a negative immunomodulation in which there is destructive cytokines are produced, symmetrical antibody, increase in the natural killer cell, decrease in the PIBF, and ultimately that product is aborted. In 1999, Clark and et al. Has done very good study, and they published a paper that why your mother has rejected you. That covers the immunological implant. Likewise, thyroid has been associated with adverse pregnancy outcome such as preeclampsia and miscarriage. What is the role of hypothyroidism and preeclampsia? There are so many meta-analyses. First meta-analysis was done in 2022 by Hedgefonga, and they had done study to assess the abnormality of thyroid function test in preeclampsia. Study was done with the selected through systematic search of Medline and PubMed with Scopus, Web of Science, and Google Scholar. Database from 31 August 2021. English studies were compared with TSH, T43 on normal pregnant with preeclamptic woman known to have normal tonsure before pregnancy. After the age of 28, that is the definition of PIH. We can say PIH is pregnancy-induced hypertension. Any normal tonsure woman developed first time hypertension with or without proteinuria, with or without enema feed, that is known as PIH. Article was assessed by Newcastle Ottawa scale. The grading recommendation with assessment, development, and evaluation approach was used for quality assessment on evidence from outcome levels. The study has done on 63 observational study was selected, used with meta-analysis. This study population included, believe me, it is 21,528 pregnant women. TSH was significantly higher in pre-eclamptic women. TT4 and free T3 were lower in pre-eclamptic women. There was no statistical significance between free T4 in the two groups. So they concluded preeclamptic women or pre-eclamptic women are at high risk of changes of thyroid function test if it is recommended that thyroid function test to be performed on women with preeclampsia. Tolozo JFK in 2002 meta-analysis, again methodology was same, author was selected on Medline, Vivid, Embrace, Scopus, Cochrane database, systematic review at inception of December 2019. This was a prospective core study with data on maternal thyroid stimulating hormone, free T4 and thyroid peroxidase TPO antibody concentration with gestational hypertension and preeclampsia. They issue open invitation to study the author to participate the consortium on thyroid and pregnancy with their said individual data. They excluded the participant who had got pre-existing thyroid disease, were taking medication on thyroid that affect the thyroid function and had got multi-period pregnancy. Outcome was documented on gestational hypertension and preeclampsia. What are the results? They had included 19 cohort comparative study. Again, the population is double, 46,528 women, of whom 39,826 women has got sufficient data that TSH and free T4 concentration and TPO antibody was status to be classified according to their thyroid function test. Subclinical hypothyroidism was associated with higher risk of prevalence with odd ratio of 1.53. Both a higher and a lower TSH concentration was associated with a higher risk of preeclampsia. So TSH has got U-shaped relationship with preeclampsia. U, that is me and you. So TSH has got very much effect with preeclampsia. So earnest request again, all the pregnant women do one-time TSH test during the first trimester. Again, very good study by Langengrad MH in 2024, very recent study. This study was evaluated whether the association between hypothyroidism and preeclampsia is caused by lack of thyroid hormone or by autoimmunity per se. Methodology was, this was a retrospective study. 2 pregnant cohort was used in Danish population. Nation-wise cohort, now you again see from 23,000, 46,000, now the number is 1,14,775. Registered base included on singleton pregnancy in Denmark from 1995 to 2015. The regional cohort, patients were 14,573, included with the biochemical measurement of thyroid stimulating hormone, thyroid peroxidase, TPO antibody, thyroglobin antibody. Among women with North Denmark region of 2011 to 2015 had a blood sample drawn in early pregnancy as a part of routine prenatal screening and chromosomal abnormality. What they had found? Again, it is a national-wise cohort and 2.2% of pregnant women with no history of hypothyroidism, that was a reference group, were diagnosed with preeclampsia, whereas the prevalence of 3.0 among the pregnant women with hypothyroidism with odd ratio of 1.13, 1.3 and 4.2 among the patient with newly diagnosed hypothyroidism pregnancy, the adjusted odd ratio was 1.6. In this region, cohort, 2.3% of women with early pregnancy with thyroid level less than 2.5 were diagnosed with preeclampsia. So among women with thyroid stimulating hormone more than 6 milliliter per unit, the prevalence was 6.2 with adjusted odd ratio of 2.4%. Considering the thyroid autoimmunity, preeclampsia was diagnosed in 2.2% of women with positive TPO antibody, that is more than 60 unit per ml, with a thyroid antiglobin more than 33 in early pregnancy with adjusted odd ratio of 0.86. You can see this chart on result that this is preference rate of 13,000 women with odd ratio of 1.9, 1.6 and 2.39. These all are the adjusted odd ratio. So we have to use levothyroxine therapy that decreases the prevalence of preeclampsia during pregnancy in hypothyroid woman. So following all this study, we know that effect of levothyroxine in hypothyroid woman in preeclampsia is fantastic. Steotis G et al. Has got impact of thyroid hormone treatment on maternal pregnancy outcome with women subclinical hypothyroidism without TPO antibody. This was a retrospective study done in 2023. Trunan et al. Has done study on pregnancy perinatal outcome among with thyroid women. This is a population-based study in 2019. All this study demonstrated that women with hypothyroidism who received levothyroxine in pregnancy did not have higher frequency of preeclampsia. So if you don't want to have eclampsia, prevent preeclampsia. If you don't want preeclampsia, do the thyroid test and give the treatment of TPO levothyroxine. Now revisit the case. Again, second case, 42-year age woman with all Doppler parameters abnormal. Now she has got 23 with plus 6 days. Ultrasound says rapid depredation of fetus with fetal acidosis, which resulting in death of fetus in few hours later. Immediately after miscarriage, hydrolysine and magnesium sulfate were administered because she was a case of PIH. In the evening, hydrolysine admission was suspended and hypertension was controlled with rifidipine. After 3 days, therapy was adjusted to 300 microgram of levothyroxine with labetalol. In 2012, when labetalol came in market, we had done study or comparison of labetalol with nifedipine and labetalol, lifidipine and alpha methyl dopa, and we had concluded that labetalol is very good drug, and labetalol we have got liberty to give up to 1200 milligram in divided doses, very good blood pressure control, and after the inception of labetalol, we had never seen too much of eclampsia cases in our practice. Otherwise, when I was in medical college, we have got separate eclampsia room, and we have got 24 bed of eclampsia. And believe me, patients, residents from other country came to visit our place to learn the treatment of eclampsia. And we had given the full dose of magnesium sulfate, keeping calcium gluconate in our hand. And we had initiated all this 14 gram of by pre-start regime. Every 4 hourly, we are giving 5 gram injections into each buttock after have negative, after seeing her knee reflex, urine output and respiratory rate. And we are controlling eclampsia very well. Believe me, antenatal eclampsia is less dangerous than postnatal eclampsia or postpartum eclampsia. So always give magnesium sulfate 24 hours till the last eclamptic convulsion was there. And while I was HOD in medical college, we had included one of the indication for cesarean section is primigravida with eclampsia, patient not in labor. Here we know that the cause is baby. So once you remove the cause, the patient has got reversal of all his complications. Number 2, we had seen the patients who have got lost their vision, patient with posterior reversible encephalopathy, posterior with Coca-Cola urine, that is hemolytic uropathy. Believe me, all these changes, all this disease, all these detrimental things during pregnancy with eclampsia, they all are reversible. So severely uncontrolled hyperthyroidism with preeclampsia resulting in that. We don't want this type of situation. So again, do TSH level as early as possible as a screening test. Now go to the third case. 26-year-old preemie, known case of hypothyroidism since 3 years, was referred to our maternity care with conception of 33 weeks of gestation. She has got first antenatal checkup at 10 weeks. When she underwent investigation, we can see TSH is 11.5, pre-T4 was 0.3. So she was asked to increase the dose from 75 to 120 micrograms. And now you see the levothyroxine available from specific companies starting from 12.5 to 200 microgram per day in divided doses. So now we don't have to crush the tablet and making the dose. Proper dosing treatment starting from 12.5 to 200 microgram per day according to her TSH level. She was lost to follow-up, traveled to another city when she did not take any medical care. Now she presented to us with 33 weeks of gestation due to painful contraction and admitted for further management. When she was presented with 33 due to painful contraction, she was known case of hypothyroidism. So we had performed investigation with TSH evaluation. TSH test revealed uncontrolled hypertension with 14.3. She hesitantly revealed that she had not discontinued treatment levothyroxine after conceiving, as she was not sure, so it was safe during pregnancy. So, this unawareness of taking thyroxine during pregnancy lead her thyroxine level not 2.4 to 14.3. So, primary with uncontrolled hyperthyroidism leads to preterm labor at 33 week gestation. So, there are risk factors which causes preterm labor with hypothyroidism. If we see the Indian case scenario, it was published in 2014 with risk factor for preterm deliveries with uncontrolled hypothyroidism, particularly in South Asia. Univariate regression analysis was used to examine the association between preterm labor with birth risk factor, which determined into odd ratio. Odd ratio was calculated on the risk factor associated with preterm and term deliveries. Among 4,137 antenatal admission during study period, 238 was remained admitted with preterm labor. So birth percentage was 5.8. It was not small percentage, but the patient study, the variables we had done: diabetes, hypertension, asthma, thyroid disorder with family history of diabetes and hypertension. You see number of cases is 154 with control of 340. You see with thyroid disorder, the odd ratio comes to 1.31. So it is a very good odd ratio that you have to control thyroid with levothyroxine if you don't want to subject your patient with preterm labor. There are lots of meta-analysis available on net. Shihan PM had done study on 2015. The aim of that meta-analysis to review the literature regarding the thyroid disease, including subclinical part, overt hypothyroidism, hyperthyroidism, isolated hypothyroxemia, and specific outcome, particularly in preterm labor. Study selection: study was considered eligible. The met with following criteria of prospective cohort study and case control study. The exposure of interest was maternal thyroid disease, including subclinical hypothyroidism, overt hypothyroidism, hyperthyroidism, and isolated hypothyroxemia. The outcome was of preterm delivery, and that data regarding the number of preterm births in each cohort was reported. The study subgroup was done by Anderson, Hitchens, Conover, Legion, Sahu, and Wiener, starting from 2008 to 2013, and you see overall odd ratio was 1.90. So in Shihan et al. 2000 meta-analysis, we had seen that there were 6 studies reporting the outcome of overt clinical hypothyroidism with preterm birth, including 2 largest studies. The meta-analysis with overall odd ratio of preterm delivery was 1.90. Sensitivity analysis by subsequent omission and individual study is not materially after the overall combining odd ratio suggests that combining odd ratio was valid and creditable. Case number 4. 32-year-old woman brought to in ambulance 6 days following the vaginal delivery at 39 week of gestation. Labor was unremarkable. Placenta was delivered by control cord section. She was diagnosed with over hypothyroidism during first trimester. You see, TSH was 3.9.2 with free T4 of 0.4. She was advised to initiate levothyroxine 75 with regular TSH follow-up, but she did not present or not follow up the consultation, and no repeat TSH was done. So she was admitted with labor with 39 week of gestation, and if you see, repeat TSH with uncontrolled hypothyroidism 19.2. So if you don't treat the patient, from 9.2 it went to 19.2. So she was admitted with lack of adherence to levothyroxine therapy. Now we have to start at 150 per day in attempt to lower the TSH level quickly. 6 days after delivery, she noticed that there is sudden crampy pain with fast loss of fluid following the heavy bleeding. Bleeding included large clots. She complained of dizziness. Pale and cool extremities are there. Blood pressure was low, 105 to 50. Heart rate was increased, so there is tachycardia, there is hypotension. Uterus was palpable 6 centimeter above the symphysis. So we know that there is sub-involution of the uterus. So this thyroid is not affecting the antenatal, it also affecting the puerperium period. Subclinical or subacute, or there is not proper involution of sub-involution of the uterus. On speculum examination, large clot was seen in vagina which were removed, and cervical os was noted to be open. So their case diagnosis was uncontrolled hypothyroidism during pregnancy with PPH 6 days post delivery. We are considering postpartum period up to 40 days or sometimes 6 week of pregnancy, 6 week post delivery. But after 6 days he is presented with postpartum hemorrhage. So this was secondary PPH and we had controlled with medication. So hypothyroidism also affects the fourth P, that is postpartum hemorrhage. Hypothyroidism associated with PPH. What is the pathophysiology? We had understood the pathophysiology of preeclampsia, preterm, and now PPH. In women with hypothyroidism during pregnancy, postpartum hemorrhage may occur because of the uterine hypotony and coagulation disorder. In case of hypotony and hypocontraction in hypothyroidism are multiple that include endogen intoxication, change in muscular tissue of myxedema implication, hypovitaminosis of B1 affecting the transmission of neural effects, and change of functional biometric scheme, and the change of interaction between the actin and myosin. You all are know regarding the natural ligature. After delivery, these all vessels are naturally ligated. Because of the hypoinvolution or hypotonia, this natural ligature mechanism is also lost, and there is postpartum hemorrhage. There is a very good cross-sectional retrospective study of 718 cases of pregnant women who are diagnosed with hypothyroidism before conception and during their antenatal period. Maternal characteristics and maternal comorbidity were noted. Laboratory data was recorded on thyroid stimulating hormone level before conception and during gestation. Maternal outcomes as pregnancy loss, that includes miscarriage, stillbirth, maternal MTP or ectopic pregnancy, gestational hypertension, preeclampsia, PPH, placental abruption, these all modalities were recorded in their cross-sectional study. Among 708 women with hypothyroid, 630 has got live birth. Percentage of PP was 38.8, very high. PPH was significantly associated with thyrotropin level more than 2.5 milli-international unit per liter, and preconceptional thyroid P value. This study was very significant with a P value of less than 0.05. So clinical postpartum hemorrhage, yes or no? The P value is very significant, 0.01. Again, this third trimester with PPH, first trimester TSH estimation, second trimester TSH data, third trimester TSH data, uncontrolled hypothyroidism is coming with postpartum hemorrhage with P value of 0.03. So again revisit the case. She has not taken the treatment. We had advised, but we are not able to convince that lady. And our counseling might be poor that we had not advised that woman to continue with levothyroxine. In previous case, she was thought that levothyroxine can cause abnormality and she was not taking the levothyroxine. Now in this case, patient was not taking thyroxine. So uncontrolled hypothyroidism during pregnancy due to lack of adherence to levothyroxine, a therapy complicated by PPH 6 days after vaginal therapy. Postpartum hemorrhage is obstetric emergency, we all know, and patient has got hypovolemic shock because we see that her C is tachycardic with BP of 105. Immediate IV replacement was done. She was given adequate fluid replacement, and recently we are doing EGDT, early goal directed treatment. That is a golden hour. We have to first treat her shock, whichever type of shock is there, either neurogenic, hypovolemic, or bacterial, or septic, and we have to give ergometrin and syntocinon. These both are uterotonic, they are controlling the uterine contraction, and initiate levothyroxine therapy and ask to repeat her TSH value after 6 weeks. So we had concluded that hypothyroidism in pregnancy may lead to myriad or series of complications. Levothyroxine therapy improves maternal outcome. In hypothyroidism during pregnancy, levothyroxine therapy improves maternal outcome in preterm. So hypothyroidism leads to myriad of disease like complication in first trimester. There is miscarriage, preeclampsia, placental abruption, change in fetal vitality, prematurity, BHA baby, increased cesarean delivery, increased postpartum, placental morbidity and mortality, and neuropsychological and cognitive difficulty in children. So those children who are not open to coping up in the studies, ask their mother whether they are hypothyroid. This is adult onset disease of childhood origin. This baby in future can sue their mother that my mother has not taken thyroid treatment, my mother has not taken iron deficiency anemia treatment, my mother has not taken PIH treatment, my mother has not taken enough iron, and now I have got cognitive impairment. So all these mothers should be investigated for this proper counseling with thyroid stimulating hormone, iron deficiency anemia, and preventing preterm. So complication of subclinical hypothyroidism during pregnancy, again I say 3 P's: preeclampsia, preterm, placental abruption, and neonatal respiratory distress syndrome. And sometimes we lose the baby. In second case, we lose the baby because of severe hypertension, Doppler changes, and proteinuria with pleural effusion, and baby die in utero. We had published 100 cases of patients with name that why baby committed suicide in uterus. These all are the cases in which there is no explainable cause was found and baby dead inside the uterus, and we see that most of these cases that is because of the uncontrolled hypertension and uncontrolled thyroid function. So levothyroxine therapy should be initiated during pregnancy. This was study done by Bain et al. In 2021. Again, it is a meta-analysis, 7 randomized trial with 6 observational study with numerators of 7,342 pregnancy. What they found? Treatment of subclinical hypothyroidism, TSH value from 2.5 to 10 during pregnancy with a low level of pre-T4 reduce the risk of miscarriage and neonatal death. Dings Z et al. In 2021 meta-analysis. Again, there is 6 study with 7,955 pregnancy, including women with TSH level more than 4. Our cutoff is 2.5 to 3. A reduced risk of miscarriage, preterm birth, gestational hypertension in women with levothyroxine treatment. These findings are correlated with anti-TPO antibody. Hypothyroidism is difficult to diagnose during pregnancy as signs can be belonging to pregnancy itself. So what we have to do? We have to do screening of that lady with simple TSH test. If TSH test found to be abnormal, hello? 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 Why you are?
Sir, you're
No, but audible, but why you are stopped? Again, there is 15 minute lapse. So I will stop at after 1 hour. This is few slides remain. So change in thyroid function.
No problem, sir. Please get.
Change in thyroid function has got negative effect on both mother and baby. Complications that arise depends on the severity of hypothyroidism, on how appropriately early treatment will be initiated, on obstetrics and extragenital pathologies associated with present pregnancy. Clinical symptoms like polymorphic, open non-specific are related mainly due to time occurrence and severity of thyroid hormone deficiency. Appropriate early administration and maintenance of normal level of thyroid hormone minimize the risk of maternal and fetal complication and make it possible that pregnancy may be carried out with severe complication. So main need is difficulty because they are necessary to enjoy the success, said by Abdul J. Kalam. The award which I had received, that is Dynamic Indian of Millennium, which I am sharing with Professor Abdul J. Kalam, and I am happy to be with him on this same platform. My paper of 2016 of progesterone was appreciated by 86 company and they are making GIO of that. So ultimately, my all patients should be happy and we don't want any complication.
Actually, the time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here.
Thank you very much, Abbott, for giving me opportunity again and again. And now any questions, I ready to welcome, I ready to answer. And now I'm stop sharing my screen. Where is my cursor? Yes. Yes.
Yes, sir.
Yes, sir. Thank you very much. Any question is there on the screen?
Yes, yes. Thank you so much.